Hello, hello, baddies. April, I'm bringing you on with me. April might have froze. Well, hello, everyone. Giving everyone a minute. I can see the viewers. Giving everyone a second to log on. April, is that you? I think April's having some.
Can you see me? Can you hear me?
I can't. I can now. You just muted yourself, though.
I did. Am I echoing?
No, you're good.
Is there echoing? Okay, good. Hey, girl. Hey.
Hello. How are you?
I am great. How are you?
I'm doing great. I love your beautiful smile. Are those your baddie earrings you have on?
These are my baddie earrings.
I love it. I love it so much.
I love your earrings too, and your shopping glasses.
Thank you. You know, I didn't think I was going to be the type to switch out their glasses with their outfits, but I got two for like the price of one this year, and I was like, oh, I'm going to swap them out like Oprah.
And you doing it, and doing it well.
Thank you. Thank you. So, welcome to Baddies Talk Back. We are, for the rest of us, the first inclusive community for women of color affected by breast cancer. My name is Jasmine. I am one of the co-founders, and tonight I have a special co-host. Say hello to one of our Baddie Ambassadors, April Finley. Oh no, I think you're frozen again. Oh no, April, I think you're frozen. We'll take you down and we'll bring you back in when you're ready. But tonight we are talking about infertility. We have the N in parentheses just because
Hi, everybody.
You're back. Can you hear? Are you there?
Uh-oh.
Struggling, guys. It's struggling. All right. So, you know what? Let me take April down until her connection gets back. All right. And then we'll bring her back on. So tonight we are talking about infertility. We're talking about breast cancer and the baby making blues. It's a spectrum. Even when you are able to have children, sometimes you have a difficulty conceiving after breast cancer, after going through treatment. So it's going to be a great conversation tonight. We have Dr. Desiree Taylor. She's going to talk to us about the mental health component with fertility. And then we have Dr. Tiffany Jones, who we've had several times for our webinar, Share Decision Making. She's going to talk to us about what the kind of options are when it comes to fertility preservation. And then we have one of the community's own baddies, Vatisha Bowler, and she's going to share her perspective and her experience navigating infertility after breast cancer. So it looks like April's trying to reconnect. And with that, I'm going to bring our guest on stage. Hello.
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 Hi.
April, you're back. I think you're good now. I think you're good.
That's a shame. My hotspot is better on my phone than the internet I pay for.
I know the challenge. That's why I don't go live from my mom's house.
You know,
you guys have seen that struggle. So I guess I can tell you guys what my experience is. So I was diagnosed with breast cancer 26, misdiagnosed at 25. I was in this weird area with chemo, and so we opted out. I pray that was the best decision all the time. I did undergo fertility preservation, and I harvested embryos, and then I ended up getting a divorce. So I have ownership of those embryos, but I don't want to have babies with that person. So that's that's where we are with that. But when I was having the conversation about fertility, actually starting my breast cancer journey, it was in the appointment that I was going to start family planning. So in this appointment where we're talking about, let's get ready to go, I found out that I have, that I need to start going down this road to explore whether or not I have breast cancer. And at the same time, I find out that my neighbor, who's about 10 years older than me, was pregnant. And that was devastating because I felt like, I'm not going to wish on nobody, but the numbers just didn't make sense, And so during her pregnancy, like, I really struggled. I struggled with the uncertainty because I was hormone receptive. So it's like, are we going to be able to carry a baby safely? Research says that we can now, but before recent studies, they were saying like, no, you should not have kids if you have hormone receptive breast cancer. Are we going to lose our ovaries? All of those questions are in my mind, and you have a very short window to make those kinds of decisions. And I don't think anyone really prepares us for the mental aspect of what comes along with having to make those decisions so quickly. So I'm still in a space of I think I have embryos. They haven't contacted me anymore. I should have embryos, but I don't even want to use them because I'm not in a relationship with that person. I don't want to have to co-parent and deal with all of those things. So it's still a little up in the air. So April, tell us about your experience navigating fertility after breast cancer.
Okay. Well, good evening, ladies. I'm sorry about the technical difficulties on my end, but I'm April Finley. I'm in the inaugural cohort of breast cancer baddies for the rest of us, but I was diagnosed in August of 2016, coming up on my 5 years, y'all, and with triple negative breast cancer. And I also have the BRCA1 mutation. So at the time, I was 35 years old. I went into 35 saying, okay, this is going to be my year to have to get with somebody, stop dating, get serious, so I can settle down and have a baby. And I was diagnosed. And at the time, I was diagnosed in August, but it wasn't until November when I got my second opinion that I actually started treatment. So before starting treatment, my doctor was like, we got to start chemotherapy. You have an aggressive type of cancer, but, we feel like you will be fine. So one of my immediate questions was, okay, what about having a baby? Mm-hmm. And the response I got was, oh, you want to have a baby? Okay, well, your insurance doesn't cover egg harvesting or fertility. So you would have to pay for that out of pocket. You'd have to do that before you start chemotherapy. You're going to have to do hormone shots. You're going to have to do this. He went through this laundry list of things I was going to have to do. And at this point, I'm looking at him like, no, let's just start chemo. But I felt like everything was so rushed. Mm-hmm. And, the entire time that I was going through chemotherapy and had my bilateral mastectomy, and I was thinking, okay, well, once I'm finished with treatment, maybe something will happen. I will be able to get pregnant before I have to have a total hysterectomy, because BRCA1 positive, the next thing is to have the total hysterectomy. And I wasn't able to. And my oncologist finally said to me, he's like, you have got to do this and you've got to do it now. It's not a matter of if, but when. So I took my breast cancer diagnosis not as heavy as I took the hysterectomy. The hysterectomy hit me like a ton of bricks because it was the reality of the life that I thought I was going to live is not going to happen. Mm-hmm. So had the hysterectomy and the pathology came back that large B-cell lymphoma was on my ovary.
Wow.
So the thought of, I thought 1,000 times, like, I'm just not going to do it. I'm going to have this baby. And then just the thought of it, like, what if I did? I wouldn't be sitting here right now.
Mm-hmm.
So, my journey with having children naturally, cannot happen. But I have a fur baby. Her name is Gigi. She's in her crate right now. When I turned 40, I said, you know what? I'm going to live my life out loud. Whatever it is I want to do, I'm going to do it. It's only me. If I fail horribly, it's okay. I have enough family and friends to support me. And I'm a mother to many children. I'm a high school counselor. Been a counselor for 16 years. So I have many, many children. So that has given me comfort. That has given me peace. But I just really feel like I want doctors to stop pushing us to the side and really just hear what we have to say. Really stop and listen. But, I'm thankful for life. I'm thankful for my dream team, my doctors. So yeah, that's my story.
You've said a couple of things that I would love Dr. Taylor to weigh in on before we introduce Katisha. So one thing that I posted about the other day is it's 5 years on hormone therapy. It may be 10, depending on what this next test looks like. But I was diagnosed. I had to do 5 years hormone therapy. I knew I couldn't have a baby. That felt like detour. And so I planned out this 5 years as at the end of this 5 years, we're ready. And then in this 5 years, I got divorced. And then I have the embryos that I don't really want to use. And then it was only recently that I realized that I was still working towards a 5-year plan that was no longer relevant. It's like, where are you going to get the baby from? You ain't got no man now. Like all of these things. And so you do go through this period where you are trying to reconcile the life you had, life you wanted, and the life that you're living. So Dr. Taylor, what kind of advice would you give to women that are trying to process that, or maybe even haven't realized they need to process that?
Yeah. I think, as you guys know, breast cancer is embedded with so many different layers of trauma. And what's really interesting about that, and what's I would say, like, something that is a failure within the medical space, is people don't use that label for those experiences. And they are like lived, it's chronic trauma over and over again in so many different spaces. Mm-hmm. And I think that I bring that up in the context of the question that you asked, because I think it's important to consider it as such and to get connected with a provider who can help you process it in that way. And not every provider is fit to do that kind of work. I think it's really important to try to find a therapist to the best of your ability who knows what it's like to work with Black and brown women, because that trauma is made unique by your identity. Somebody who can process what the impact of that health experience was like for you, as well as like the fertility piece. And you'd be really surprised that there are providers out there who are specialized in those areas. So I think that that's a big component of navigating this, is making sure that you have a good quality provider that you can speak with and talk about these things over and over and over again, all of the things, all of the traumas. Because they happen, and then at various points of your life, you relive them in different ways, depending on, what you're facing, right? You're coming at this, or you were kind of implying, Jasmine, that you're coming at the end of this like 5-year period right now, right? So now you're navigating, the trauma of fertility, but also you had this relationship that you lost in that process, which is layered into that as well. And you need a space to be able to talk about those things. And unfortunately, if your family is anything like my family, nobody wants to talk about those things. Sometimes they want to talk about the fact that you're here and that you've survived cancer, and like, praise God, what a blessing. But there's been so many losses that have been embedded within that blessing. So when you reach out for support, the reason sometimes to pursue support like a therapist is because you need a space to be able to process that loss and all of the beautiful things that you're still living out, and the gratitude that you're experiencing as well. And that's a very unique kind of support that you need, right? Like what I just described was a lot. So
You know, one thing that we learned from Ayana Zandari, we've had her on a couple of times for our mental health webinars. She talked about how feelings aren't mutually exclusive, how you can be grateful and you can be sad at the same time, and that's okay. And I think we've been trying to encourage women to feel all of their feelings. Like, yes, we're grateful to be here, we're grateful to be alive, and we're sad that we're dealing with some of the collateral damage that we went through so that we could live. So, Batisha, tell us about your experience with fertility. Where are you right now?
Well, good evening, ladies, and thank you so much for having me on. I was diagnosed with stage 2B invasive ductal carcinoma in 2013. So I'm coming up on my 7-year anniversary tomorrow.
Oh,
All
congratulations.
right.
Thank you. Thank you. So, um, when I was diagnosed, I got diagnosed in February of that year, and when I went to see all of my breast surgeon and my team of doctors, my breast surgeon actually, I was fortunate enough. My breast surgeon, he actually told me about before I started chemo, getting my eggs, having doing the egg preservation, but I had to make that decision so quickly because I was 30. I was diagnosed at 36. Wasn't not married. Don't have any kids, and that was one thing that I wanted to have. So when I got diagnosed, that was the first thing that came up to my mind. Oh my gosh, am I going to be able to have kids after this? So when he brought up about the egg preservation, again, I had to make that decision like within days. So I started that process the first week in March, and it took that entire month before I started chemotherapy in April. So having to do all of that, so I have 7 embryos that are preserved, and I have them until until I turn 50. So which is I'll be 43 this year. I mean 44 this year, excuse me. So I got 6 years left, and it's like so many things are going through my mind. Although I'm coming on, on the eve of my 7-year anniversary, I still have that reoccurrence anxiety in the back of my mind. What if, when I do decide to have children, and I have always wanted to, I want to have a 2-parent home. So it's like, well, what if, I do use the embryos, I get pregnant, and then the cancer comes back.
Mm-hmm.
I have all these questions. What will I be able to breastfeed? Because I see when I was going through my breast cancer journey, all of my friends and my circle of people, they were starting new chapters in their lives, getting married, having babies, and it's like, why did I'm going through this particular journey? And there were moments where I was happy for them, and I would congratulate them. But then as soon as I got off the phone, or after talking to them, I would just burst into tears.
Yeah.
And
Yeah.
it wasn't so much as I wasn't jealous. I was just angry. I
Oh,
was
yeah.
angry. I was just a ball of emotions. I was
Yeah.
angry. I was hurt. I was like, why? I was in that why me stage.
Mm-hmm.
Um, and now, the what's really concerning me is that I feel like, again, I have my embryos until I'm 50. I got 6 more years left. And it's like, okay, am I going to be able to do this? And I know women are starting families later in life. I get that. But then I not only think about that, but again, I think about, okay, what if the cancer comes back? So,
Mhm.
and that's a big part that I think about, will I be able to successfully carry a child? Because I'm 4'11", and my body has gone through so much within the past 7 years. So those are the things that I think about, that are constantly in the back of my mind. um and that's where my journey is at this point. I know that, like, I'm currently seeing a therapist, and just like excuse me, just like you said, having someone to talk to, having that third person somebody objective, who has that more objective opinion, that you can just get all of this out, because when you do talk to family, their biggest thing is, oh, just we thank God that that you don't have the kid, you're cancer free. But we have so many other things that we're having to deal with. And just like April, I'm an educator as well. I'm a kindergarten teacher. So, I'm a mother to many. And my own mother has said that many times, even though I don't have children of my own, those are my babies. But I want my own.
Oh, baby.
That
Yeah.
and that's what I try to get her to understand. Even though I've been teaching so many years and I've had babies, kinder babies come and go, it's not for me. It's nothing like having your own. I want them to come from me. So that's where I am in my journey at this point.
Right. Tisha, you said something that sparked something in my memory. One of the things that I constantly thought about in that window of time before having the hysterectomy was, do I want to pass this gene on to my child?
Mm.
And
Yep.
my grandmother is a 2-time breast cancer survivor. 3 of 4 of my aunts, her daughters, are breast cancer survivors. I was the first grandchild to be diagnosed with breast cancer without children under 40. And after my diagnosis, within 3 years, there have been 4 additional first generation granddaughters diagnosed. Some who had children, some who had not.
Mhm.
And all I could think about was, I wanted, like you said, I wanted to have my own child,
Mhm.
but I didn't want my baby to have to suffer with what I had to suffer through.
Right.
Mm.
Right.
And I mean, that's a big pill to swallow. That's a huge decision to make. Like, you put yourself on the back burner to stop, and in a way, stop your lineage because not having a baby.
Yep.
And for our parents and our grandparents, it's a rite of passage to be a wife and to be a mother. So
And that
here
has
you are,
always been
it's
my
like,
desire. And that has always been my desire,
yeah,
to be a good wife and a good mother. But like
yeah,
you said, I have those fears too. What if I'm breastfeeding and God forbid, I pass it on to my children through that, or am I, like you said, just passing that gene on to your children? Those are things that we do think about, and that is a hard pill to swallow.
yeah,
So I think a couple of things. We've got Brittany that talks about feeling selfish. And I think I've had that thought as well, because even though I didn't test positive for a gene, they were like, it's likely a gene because it runs so prevalent in my family. My grandmother's 2-time survivor. She's living with metastatic breast cancer now for the 3rd time, after she was diagnosed for the 3rd time. And so I definitely went through those things like, is it selfish to want to have kids? Because something went wrong with me and I don't want something to go wrong with them, even though like we don't know, right? We don't know if it's like a for sure thing. But I also think there's also an education piece to that, is understanding how can we work with genetic counselors to say, like, what are the odds that I will pass this on to my children? And that way, when we are more educated about the way that the genes work and things of that nature, I think it'll allow us to make better decisions and more informed decisions. But one thing I think we've all talked about is how fast this happened. I know when I was asking questions, being on Lupron and tamoxifen and all of those drugs for like these 5 years, I remember asking them how these kinds of medicines affected my fertility. And I was told, like, worry about the cancer now and kids later. And
yeah,
my response to that was, well, what if we make a decision now that won't allow me to have kids later? And then I'm kind of SOL. So Dr. Jones, when is the best time? So, and I will say this too, that my oncologist actually didn't, like I said, they weren't really want to have a conversation with me. I went back to my OBGYN because that's the person that kicked off the testing and all of that stuff. I went back to her, and she was the one that said, no, let's go do some fertility preservation. I didn't even have that conversation with oncology. So, Dr. Jones, when is the best time for someone to come into your office, and what kind of options do they have nowadays?
Yeah, so unfortunately, it is something that has to be talked about immediately. There isn't a lot of time because no one wants to delay, potentially life-saving treatments of chemotherapy and surgery. And typically, the window from diagnosis to treatment is about a month to 6 weeks. And that gives us enough time to do an egg freezing or an embryo banking cycle. So when whoever diagnoses it, that should be part of the conversation right then and there, and giving a patient time to think about it. It's not a lot of time, but at least a little bit of time to digest it. I think giving a laundry list of negative things isn't really a counseling session. That's a deterrent, and a lot of the, especially the oncologists who see really bad stuff, they see a lot of their patients pass away. They're jaded in a sense where, all their focus is on is saving your life, which is to be applauded. But it's up to the patient, because people survive, what that survivorship looks like. What do you look like when you have beaten cancer and someone's taken away something that, a lot of couples, a lot of women, a lot of people feel is a very important aspect of the life you saved, is procreating. So I do think the oncologists aren't really educated on the newer techniques of freezing eggs very expeditiously. So typically, when a patient walks in, we can get it done in a 2-week span of time. Typically, it was, you have to wait for a period, which depending on where your cycle is, it could be anywhere from the next day to a month later. And that's going to delay your therapy, and no one wants to do that. But that's not the case anymore. There's also newer techniques that some people perform that are actually harvesting the ovaries, which is only one surgery. And then you don't have to expose yourself to any hormones, any elevations of estrogen. And that tissue can be saved and potentially reimplanted, or eggs can be harvested directly from the tissue. Another thing that oncologists don't know is that we put you on special medications like letrozole, things that they would put you on, or tamoxifen, to actually keep your estrogen low. And so it's a team approach, but a lot of them, this year, I know COVID and everything, but I haven't had any people refer to me to egg freeze, like not one. And I know people are being diagnosed. I know young women are being diagnosed. So I hope they're going to somebody. But my fear is that, even when I talk to the oncologist, it's really hard. An OB-GYN is likely to talk to you about it. But if you get diagnosed by radiology and go straight to a breast surgeon, you may miss that avenue.
Absolutely. And I think in the grand scheme of things, like you say, like their focus is on cancer, and to an extent, like that's our focus too. Mm-hmm. But one of the things we had this conversation recently is that we don't normally talk about quality of life until it's end of life care. And really, quality of life should be like at the very front and center of these conversations. What do you want your life to look like at the end of this? And we don't have those conversations, and it puts us at such a disadvantage. So, Dr. Taylor, I think another theme that I'm seeing here is how do we navigate the uncertainty? Because I'm hearing Tisha talking about this ticking clock. I was working on that ticking clock until recently. I had to take the timer off and be like, I don't know what's going to happen. Like the odds of me getting married and having a baby by next year is that's really slim, right? Yeah. So I'm having to turn that timer off. But even that's a moment of grief for me, because it's like I was looking forward to that. Now we're just saying, like, I am really just trying to really give it over to God, this timeline that I had in my mind. So what are some ways that we can grieve the timeline that we have in mind.
Yeah, and the uncertainty. So I think I want to say one thing. I wanted to just let you guys know this based on my knowledge of the research. Many women who are navigating a breast cancer experience will report more distress related to fertility than the actual diagnosis itself. So the fact that that is not like an embedded conversation with like a built-in structure, with like a built-in referral to a fertility specialist within that space. And some programs are like that. Some programs, they do take those conversations seriously and might even have like an onco-fertility program embedded within it. But I just wanted to name that the distress regarding fertility can be actually higher than the distress related to just hearing that you have a breast cancer diagnosis. I know they're embedded, but I think you guys know what I mean.
Yeah.
But back to your question about uncertainty, I wish I had like the easiest answer, like when you're feeling uncertain, do this and it's going to go away and you're never going to feel that. But I don't have that answer. But in general, the things that I talk to you about folks when they're navigating fear and uncertainty, almost always first is giving yourself the time and space to recognize and acknowledge and feel those emotions. We are very quick to like want to get rid of something, want to numb something in whatever way, whether it's through alcohol, through busyness, through distraction, through television. And feelings and emotions don't work that way. We have to actually process them for them to change. Does it mean it's going to go away completely? No. So I think when you're experiencing uncertainty, which is likely to come up quite often, it's not just going to be something that hits you, you know, once a year. It's important to acknowledge it. It's important to spend some time with it. Like I always talk to people about just understanding where you're carrying it in your body and like locate it there and to investigate it. Like, what does this feel like? What is this about? Underneath the uncertainty, what are my fears around this? Like, what am I really toggling with? And stick with it. And once you've spent some time understanding it and being with it, not getting rid of it, think about how you want to nurture yourself in that regard. And sometimes that might mean, reaching out to a friend and having a conversation. That might mean something basic, putting your hand on your heart and just acknowledging that this is a painful experience and it's an ongoing experience that you're stepping into. So I think one of the biggest things that I say to people about navigating those difficult emotions, complex emotions, is being with it. But the second part is also, and this is where the medical advocacy piece comes in. Many of the things that you guys listed around uncertainty, there are a lot of spaces where you can ask those questions. So for the things that you are uncertain about, they may also be the things where you can get some data and some information around it and get some statistics that actually help to, it doesn't make things certain, but it gives you some science around what to expect, what not to expect. So being a medical advocate for yourself and reaching out to those resources around you and answering those questions and basically just working on the things that you can control, I think is important.
One of the things you said, being a medical advocate for yourself. Mm-hmm. In communities of Black and Brown people, how do we advocate for ourselves? Because we come from a culture, if the doctor said it, that's what it is. The doctor said it's not a problem, so it's not a problem. And then you get down the line and it is a problem. Mm-hmm. So my question to you both, Dr. Taylor and Dr. Jones, how do you do that? How do you advocate for yourself when you know is, but you know?
Yeah. One of the biggest ways, especially in the beginning, is I always tell people to bring a really strong advocate with them, because when you're first learning about your diagnosis and literally your decision-making process, your cognitive faculties is totally shifted by the fact that you are in fight, flight, freeze modality. So you really need a strong force to be with you. I always talk to people about I think I was looking at the website today, Living Beyond Breast Cancer, and I was looking up an onco-fertility guide that they had on there that had like some pre-listed questions that you can ask your provider. It's a matter of getting on the internet, writing your questions down before you get into that space. I always tell patients when they start a session, not a session, but a visit with a provider, to like make it clearly known in the beginning, I have 5 questions that I want to ask you today that are really important to me before we get started. So I know you have a lot to do, but I want to get to those 5 questions if we have time for that. Because doctors move fast. They have a ton of people to see. So by like putting that marker at the beginning of the visit, you're like kind of cracking the door for yourself so that you can make that quick pivot later on and not feel as uncomfortable about it. That's one of the ways that I talk about medical advocacy with folks. And I'll let Dr. Jones speak to some other ideas as well.
Yeah, I think bringing someone who is a strong advocate is really important because, like Dr. Taylor said, it's a whirlwind. And so if you have someone who is listening from a different type of ear, they can help in that sense. What I say is, the other thing I say is, when someone sits down, whatever diagnosis they have, is that doctor listening, right? And so if you come in and that's all I'm doing is asking rapid fire questions and you never get to just talk and ask questions and it's too rushed, yes, we are rushed, we are busy, but this is a very sensitive life and death thing, and it can't be a mill, right? This is you. And so one is, if you vibe with that doctor, schedule, say, hey, I understand we're, busy. I have some other questions. I'm going to schedule another appointment where I just want to, take some time to digest this and then come back and then talk about it. Okay. And then, get that extra time, because you can get extra time. I think second opinions aren't used enough. Getting a second opinion does not mean you don't like the doctor, you don't trust the doctor. A second opinion is, now this doctor done told me all this stuff, and I'm just gonna make sure that this is all the stuff that's true. And then you don't gotta even go over all that stuff. Let me ask you some of the questions I'm concerned about what they said. You have to do, you really have to do that. I don't think anybody should undergo such life-changing treatments or surgeries or anything without just making sure that this is the only option or this is all the options, and they vibe with that person. And I know it seems like there's no time, but like I said, usually it's about 4 to 6 weeks. And I had a breast cancer patient who she saw 2 or 3 doctors, and before she found who really she felt was going to care for her in the way she needed to be cared for. It's not a one size fits all type of thing. I'm not scared of Google. I know people are like, you're not Dr. Google, stuff like that. Everybody Googles. You do have to do your own research in a way too. Not that you're going to be completely, knowing all the medical books, but when someone tells you something, you should be able to find it somewhere, if it's not being made up. And then, somebody should be able to dispel things that maybe you have interpreted incorrectly. It should be a dialogue between a physician and a patient. It's not anyone telling you anything and you have to do this. And if that's what your doctor is doing and you're not comfortable with that, a second opinion and changing that physician is really important. You can't be so scared that one day, 1 hour is going to change the whole course of your diagnosis, because likely it's not. But one bad doctor and one bad move, one bad misstep, when you already had that spidey sense, that could really mess you up. So I think that's a big part of advocacy too, is just not being scared because this is the first person you met. There's lots of doctors out there that may be able to serve your needs better.
I think those are great points, Dr. Jones. And a couple of things I want to note, especially in terms of processing your emotions. I don't think most of us are able to process our emotions until the end of active treatment if we have an end of active treatment.
Mhm.
Because I think you're focused so much, it's like boom, 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 doctor's appointments every day, and then suddenly it's like a oh my gosh, what happened? So I think that also makes it a little difficult. It makes it a little difficult to process because like your mind can't even keep up with all the changes.
You can't wrap your head around it because it's just so much that is coming at you as far as all this information, and the diagnosis itself. Because as you know, Dr. Taylor and Dr. Jones was talking about, advocacy, having someone there with you. I thank God for my mother.
Me too.
She was there meeting my team of doctors because I had no clue what to ask. When we talked to my fertility doctor, she knew the questions to ask, and I'm just thinking, I don't know if it was just divine intervention or because she was a mother herself, she knew what to ask him because she knew that was a desire that I had. But because all I kept thinking about was, oh my gosh, I got cancer. That's the only thing that was going through my mind. And what am I going to have to do? How sick am I going to get? So, those for asking those fertility type questions, she was able to do that. And I was fortunate enough with the doctor, we had that conversation. So that he sat with us and he even asked, is how can I make you more, feel better about having this procedure done so that you can get started with your treatment. So he made the decision easy for me. And I know that not every doctor is like that, which I feel as though all doctors should, because again, we have so much that we are trying to wrap our heads around. That's just one less thing that we need to try to make our journeys a little less stressful for us.
Absolutely. So Nadia just posted like a great comment, and I'm going to go to that. But before I do, Dr. Taylor, are there ways that we can help? Now, April spoke this a little while ago. This idea that culturally, self-advocacy in the medical space is just not. It's not our thing, which is interesting because you would think it would be because of our history of medical mistrust, but it's really not. We are doing a study right now on race, culture, and clinical trials. And some of the preliminary research, it's showing things like in terms of barriers, let's say that transportation is a barrier. It said that white women talked about transportation more, but only because they were talking about solutions, finding solutions for transportation to get to clinical trials. Whereas Black women were talking about transportation, they saw it as a barrier and they didn't move beyond that. In the book Outliers, it talks about how successful people spend more time, like 22 minutes, I think it's on solving a problem, and unsuccessful people spend like 2 minutes on solving a problem. So when it comes to self-advocacy, are there skills that we can help women cultivate to find their voice, to get more comfortable talking to doctors, because it's not something that may come naturally to them?
That's a good question. And I feel like I need to think about that to like give a really good, robust answer. But I think off the top of my head, some of the things that, if it was a family member of mine, like if I was thinking of some of my family in Birmingham, Alabama with a recent diagnosis, I would encourage them to always prepare for a visit. Like a part of the process, I think, of not spending time talking about transportation is because we're uncomfortable asking those questions, because what is that person thinking about me, right? Like, if we are bringing up that we are having challenges with transportation, what other assumptions, might they be making as a result of that? And so let me manage the situation by not putting that information out. And remaining quiet so that I can kind of minimize additional experiences of stigma. But I think that preparing for your visits, writing your questions down ahead of time and practicing them with people. And I say that also, like, just working with so many individuals who are navigating cancer, I know it's a whirlwind. And so that takes time and energy and effort. And sometimes you don't have time, energy, and effort too. But I do think that that's an important part of self-advocacy. I also think asking within programs if there's somebody like a cancer navigator who doesn't like have the jacket on that looks like a physician. They're not giving you the vibes of a doctor, and they may even speak differently. That may be something that women of color and people of color just, and sometimes navigators are women of color, sometimes depends on where you are. That might be a person that is easier to talk to and actually is processing the fact that there are these barriers that exist out there and are more likely to actually ask you the question in a way that you might spend some more time on it because they know that these kinds of things exist within systems. And one of the things I've always been shocked by, even I work with oncologists who know that there's navigators, but they're so busy and focused on the specific details of your care that they're forgetting about that and they're taking those things for granted. So I think women of color, asking about some of those additional resources within programs is another way to advocate, you know. But also, these are all things that somebody has to be thinking about advocacy to even do these things. Yeah. And so somebody has to be encouraging somebody to think about advocacy. So I think it's our jobs to be telling people and sharing that and getting that message out. So yeah.
This sounds like a 5 ways to prepare for your oncology appointment to me blog is what this sounds like. So like I'm with that. I love all of that. But and when you talk about stigma, I also think that probably goes against us in terms of why we don't advocate for ourselves. I wasn't misdiagnosed. I don't think I would have been very mindful about it. I think being misdiagnosed made me key in like, oh, they're messing up sometimes. They're human. They make mistakes. And now I need to understand why things are happening the way they are. But then when you think about stigma, you think about, especially for Black women, you don't want to be the angry Black woman. You don't want to be the difficult patient. You don't want to make other people uncomfortable. And I think we have to get to a place where, Shantae Randall, she's one of my friends. She, one of our OG metastatic baddies, she passed away almost a year ago, which is crazy. But she texted me one time. She said, like, how do I get over being the angry Black woman? I said, well, sometimes we have a reason to be angry. Sometimes we have a reason to be upset. And I think we're going to have to get over that fear of they're going to treat me differently or mistreat me if I don't stick up for myself. They're going to mistreat you if you don't stick up for yourself.
That's a good point.
You know what I mean?
Absolutely.
Yeah.
That's a good point. That is a really good point. Yeah, that happens. And doctors are people. I work with a lot of doctors. They're my patients too. And they're out here struggling and they make mistakes, and medicine is a practice. It is not perfected. And so if I had to give somebody a recommendation, it is going into that office and looking at that person and saying that is a person who has flaws and that is a person who is hurting and suffering in ways that they may not be sharing with me right now. So let me remember that as I'm interacting with them, because they are a person just like I'm a person.
I think that is beautifully said.
Absolutely. Well, we've talked a lot about the emotional side and the mental health side of infertility. I want to come back to Dr. Jones because there was a question that came up that's pretty interesting. When you're treating patients with breast cancer diagnosis, do you treat a triple negative breast cancer woman differently than one who is hormone receptor positive? Is the treatment plan different or is it similar? Can you elaborate a little bit on that for us?
Yeah, I think most of us treat them both the same as far as, if you're freezing eggs or creating embryos, no one wants estrogen high in a breast cancer patient, regardless of their receptor status. I think you would probably forgive yourself if you didn't give letrozole or tamoxifen to somebody who's triple negative, but we would probably do the same protocol. I mean, I do the same protocol. I just keep estrogen low because it doesn't change the outcome. And there's really no reason to have high estrogen, but it probably doesn't make a difference in the triple negative breast cancer.
I think that was actually the first time I was introduced to Lupron was when I was going through the egg preservation process. And then once I finished radiation, I've been on Lupron ever since. So April and Batisha, I think this is a great question for you all, and probably for some ladies in the audience. We'd love to see your thoughts. How has breast cancer forced you to redefine motherhood?
Tisha, you want to go first?
I'm thinking. Go ahead, April.
Ooh, I gotta take a sip on that.
Yeah. That's a question for. Thank you, Jasmine, for that question.
That's a great question.
Yes, it is.
For me, I started with, I just don't give a damn what you think. I've spent so much of my life caring about what other people thought about me, living up to the expectation of others or what others wanted from me. And at this point in my life, I just don't care. And that's important when you're a single woman.
Yeah.
No husband, no long-term boyfriend that people know about. Because seriously, because people create a narrative about you because you don't have those things, or those titles in your life, and I just don't give a damn.
Yeah.
I saw that Nadia said that she went and spoke to someone about adoption a couple of weeks ago. I applaud her. That is a courageous step. Because with all of the talk about being a single parent and the roles of being a single parent and a child needs both their mother and father in the home, don't get me wrong, I agree with all of that. But who's to say that I can't provide for my child just as well without a permanent man that I'm in a relationship with? I could have an uncle, my father. I could have a best friend that's a man that could pour into my child just as well. So motherhood for me, like I said, I just became a fur baby mom. I love my dog. I was told over and over again, you don't need a dog. You're not home enough. You don't need a dog. And all of those things may be true. But the joy that I feel when I walk in the door and that little dog is excited to see me, I can't explain that. And even with the thought of now, well, maybe I do want to adopt a child. I'm kind of the off the record mom for one of my former students who was an orphan of the state. She is nobody. And, I spend time with her. I go with her to doctor's appointments, of course, give her money or things that she needs. And at first it was kind of like, well, I was keeping it a secret because I kind of didn't want to hear what other people, I don't give a damn. It don't matter. Because at the end of the day, what matters is what I feel, the life that I live. So if I close my eyes tonight, my life has been fulfilled because I have been a mother to a dog and to a young lady who doesn't have her mother and her father have gone on to the other side. So for me, I still mourn the life that I wanted to live, but I'm so excited about the life that stands before me. Because I'm going into, it must have been something with turning 40. I'm walking into this thing like, what's up? What we gonna do next? Right. I'm even surprising myself with some things because it's just, life happens so fast.
It does.
And I'm just holding on to these wins, these little wins, these big wins.
Yes.
I'm holding on to that because I didn't beat cancer to just be stuck and upset and mad and angry.
Facts.
And that's and you know what, and I'm gonna piggyback off of that, April, because that's where I am. Motherhood for me now, I want it now than badder now that I wanted it before I had breast cancer. I feel for me, I went through with my breast cancer journey. I feel it was a life or death situation. At that During that journey, I didn't, there were so many uncertainties, and it was something that I had always wanted. But now it's like come hell or high water. I hold on to that hope that it's gonna come. And I know I keep telling myself, I'm like, okay, if I got to be Janet Jackson and have my first one at the age of 50, then damn it, I'm gonna be a badass mama at the age of 50.
That's right.
I will never forget when I was going through my breast cancer journey. My assistant principal told me, she said, a lot of people when they get older, the older they get, the more energy that they tend to lose. They get tired a lot. She said, with you, it's like you're going backwards. So it's like the older you're getting, the more energy you have. And she was like, that's just God's way of just preparing you when it is your time for you to have your children and you're going to have them later. You're going to have the energy to be able to keep up with your kids. You're going to have the means and the resources to be able to take care of your kids at whatever age that it is. So if I have to be 50, Karen having my first baby, then so be it. So
Absolutely.
yes, so motherhood for me, I want it now more than anything, and I do believe it is coming.
Right now, like I was separated for 2 years. I've been divorced about a year and a few months. Starting to date again. And like I said, it was a recent realization that I was still working towards my 5-year baby plan with like no man. Like that was like a couple weeks ago that I realized like, oh, we need a whole new plan. But I right now, like my businesses are my babies. This is what I think God is wanting me to put my time and attention to. And it's crazy because my mom said the other day, she was like, oh my gosh. My mom, like if anyone ever, if you ever talk to my mom is like waiting on babies. Like she bought clothes like 5 years ago. Okay. Like she's been waiting on babies. And she was like, so she said, there's no way you would be able to do the things that God needs you to do right now if things had went the way that you wanted them to go. So right now for me, my businesses are my babies. And I want children, but I feel like being in a space where I don't know what's next. I know what I want, but I don't know what's next. It's like closing your eyes with your hands on the steering wheel and just like letting go and being like, God, guide me. Like I'm going to get where I need to go. Mm-hmm. But I'm accepting that I'm not the one steering the wheel, So I think that's got me in, I don't know. It can be scary, but it also brings about a certain amount of peace as well. One thing I tell people all the time is when I was diagnosed, the first thing I heard was "it is well," and to me that means like no matter what it is, it's okay, and okay can be different things. And I think I'm trying to find peace and okay, whatever okay is.
Absolutely. Yep. Jasmine and Tisha, I want to say to both of you that through your work, you have birthed a whole culture of women who are advocating for themselves, who have a space to talk about what is happening to them, talking about their experiences, touching other women and connecting and sharing information that wasn't present 2 years ago.
Right.
So all of your work, all of your hard nights, all of the things, the labor that you've gone through has birthed this, what we're doing right now. Tisha has a podcast once a month, Tisha's Tea Room, where we're talking about breast cancer. And then for the rest of us, this is your baby. And I'm just so thankful to be a part of it, because just imagine if we didn't have this,
right?
Where would we be?
Where would we be?
So many of the women in our community, where would they be? Yep. So many lives have been changed and saved because of the work that has come from you, from what you have birthed. So I thank you both for that.
Well, thank you. And we're proud to have you on our team, April. You know, there is no us without the community, literally. And so great things have happened and greater things will be happening. And as we're doing this conversation, I have all these ideas and I'm like, why isn't fertility conversation mandatory when people are diagnosed? Why is it okay for that conversation to be skipped? Why is it okay for doctors to do, like you said, Dr. Jones, like they're deterring us is what it is. Like, we don't have time. But we like, let's just take those 6 weeks or 6 weeks to make a better decision that's going to affect the rest of our lives.
Sweet.
So, ladies, like this has been a wonderful conversation. I am so grateful to have been in your presence tonight, and I'm so thankful that everyone was able to share their expertise and their experiences. If you are still logged on with us, remember right now you can participate in our Breast Cancer Awareness Month campaign called Breast Wishes. Marissa is going to drop that link. And what we're doing is we are putting together songs that make us smile, personal affirmations, quotes, all the good things that may encourage someone on a random gloomy day, and we're going to put it all together in something really cool. So make sure that you participate in that project. Ladies, do you have any final thoughts before we log off?
I did want to say one thing about genetic testing, and April had brought it up. I just want to make sure that people know that even if you have a BRCA gene that is autosomal dominantly expressed, meaning you only need one of those genes, only 50% of your embryos or your children would be exposed to that or potentially affected. And when you create embryos, they can be genetically tested and screened for that gene so that you don't have children, if that's your desire, that are affected. And so I just wanted to let people know that's an option, because obviously your oncologist wouldn't know about that. But if you don't get to a fertility doctor, just know that you can screen embryos for things like that, and make those decisions for yourself.
Wow. Wow. Thank you for sharing that. We're definitely going to be tapping you both, Dr. Taylor and Dr. Jones, because we are coming up with some things, different communities where we want to make sure that we share this information, this life-changing information. Had I known that, I might have harvested my eggs, who knows, but it is what it is. So I think Jasmine's camera has dropped. So ladies, we would like for you to stay on for just a moment so we can get our group shot together. But to everybody who has joined us tonight, thank you for joining us. Thank you for being with us. We hope to see you back here next month for Baddies Talk Back. Have a good night.
Bye.